on certain populations. And then I've been working in the Respiratory Clinic at Cambridge Health Alliance, so I'll be sharing some case studies with you. So Rebekah, are you there? All right, hang on just a second. Let me see if I can find her. All right. Yes.
Perfect. So sorry about that. I'm on my fiance's computer now, and hopefully that won't happen again. Are we ready to, am I ready, Kathe?
Yes.
Perfect. So hi everyone, I'm Rebekah. I'm a family medicine physician also at Cambridge Health Alliance. And so just an outline for tonight. I don't know if you've been over this yet, but we're going to talk a bit about social determinants of health, and then discuss a few different examples of this as they apply specifically to the COVID pandemic. And then we're going to go through some cases that Kathe has had in our outpatient respiratory clinic, and then a case that I've had in our ICU, and then there will be more time for discussion throughout the presentation, but then also afterwards. So first of all, we're going to try to keep this a little bit interactive, so if people could try to speak up. What are the things that you think about when you hear the term social determinants of health or health equity?
And you'll feel free to unmute yourselves if you'd like to chip in your thoughts.
It's like all things outside of the traditional medical things, like just like things like access to food or education, or like where you live.
Yeah. Great, yeah. Any other people, other examples of what might be social determinant?
Could be access to health insurance as well.
Yeah.
I wanted to add that it could be also like food insecurity, housing insecurity, childcare access, basically anything that can impact the individual from kind of being able to utilize services. It could be transportation as well.
Mm-hmm. Yeah, that's great. So all of those are really excellent examples, and we're going to touch on some of them over the course of tonight. But the CDC and WHO and a lot of other organizations define social determinants as the conditions in which people are born, live, work, play, and really anything from the structural aspect that can affect an individual's health. So I first just wanted to actually touch base about this COVID tracking project. Don't know if Kathe, you can click on it. Perfect. So I'm sure a lot of people have heard and or seen in their practices or professions about some pretty significant disparities in regards to how COVID is affecting patients so far. There's unfortunately not a lot of data that our government has published in regards to racial disparities or socioeconomic disparities. And so I found this COVID tracking project actually quite helpful. It goes over the number of people who've tested positive, the number of deaths. And then if you scroll down further, Kathe, there's actually a component to it which specifically talks about racial disparities. So I think it's this next part. Yeah, so it's the racial data tracker, which actually gives a lot of really robust information to really better define how COVID is affecting people depending on like race or ethnicity. And we're seeing, obviously, as there's been a lot of coverage in the media, that COVID, it does actually discriminate in a way, in that it's affecting people who are more vulnerable, higher risk, and a lot of people of minority populations. So I think this is a really great resource, especially given that the resources right now for for health inequities during the COVID pandemic, the data is pretty limited.
Sorry, guys, I don't think that's very useful.
And there's actually, if you click into the web version, there's an entire spreadsheet that's broken down by a lot of different counties for the number of positive tests and deaths per county level, depending on race. And so, and actually, Kathe, if you want to just go back to the slide set, I think the slide set will be made available, and you can also check out the COVID Tracker project on your own. So this is great, yeah. So I just also wanted to touch on a few different social determinants, especially as I've seen so far in regards to the COVID pandemic. Socioeconomic status especially has been a big factor. We've seen that there are a lot of people who are less socioeconomically well off who have been really affected by this, and we'll talk about some of the reasons why. So first of all, just like someone mentioned a few minutes ago, our neighborhoods that we live in actually really significantly affect our health. And so in regards to COVID specifically, our neighborhoods may determine or influence housing conditions, safety of outdoor spaces, and our housing conditions, especially with COVID, things like overcrowding are really significant, and also decreased sanitation. And then safety of outdoor spaces, that might not seem quite, or maybe it does, but it's important in the fact that safety of outdoor spaces affects our risk for COVID, because if we're able to safely exercise or get outdoors, you're at less risk for comorbidity, which we know is a more protective factor for COVID. And then also, if people have safe outdoor spaces, they're able to better physically distance, all of which affect our risk for COVID transmission and also complications from COVID. And then socioeconomic status also influences things like healthy foods and nutrition, which is also largely influenced by the neighborhoods we live in. So a lot of healthy foods are less financially accessible. And then there are also a lot of neighborhoods that have food deserts. So maybe that means there are places to get food, but you can't get healthy foods. Maybe that means you have less access to things like Whole Foods or Trader Joe's or anything that has healthier foods available. And that when those foods are available, they often are more expensive. And then obviously healthy foods affect our risk for comorbidity and our susceptibility for complications from COVID. And then next, I think someone also mentioned education. So really starting to think about education level. Our quality of primary and secondary education is also largely dictated by socioeconomic status in this country, where school districting is not always equal or equitable. And the quality of primary and secondary education that people get often can influence their future educational plans or professional trajectory, which either can reinforce or evolve one's socioeconomic status. And then socioeconomic status in regards to the COVID pandemic does obviously affect a lot of these things that we're talking about tonight. So I think from a COVID perspective, this is really key. And then I think it's also important just to mention that that quality of education is also a really big component in regards to health equity right now. Sorry. And so there are a lot of people out of school during this COVID pandemic. A lot of people's parents are able to educate them from home, but a lot of parents are not. So that creates some pretty significant disparities when it comes to our educational system right now in America. Even thinking about like doing schooling from home, some people have much better access to internet or laptops or other computers or devices than other people, which even further exacerbates those disparities. And then again, just talking about the type of jobs that people work. So thinking about COVID in particular, a lot of people are now working from home. And so a lot of people do have the opportunity to work from home. A lot of people don't. And so this affects people's ability to physically distance. And then also just thinking about the people who are required to report to their jobs in person for work, that a lot of those people are also requiring public transport if it's available to get to work. So just going to work increases their risk for COVID transmission and complications, but also even more contacts or touches on public transport can significantly increase their risk. And then I think that, it's really important to know, I noted at the beginning when we looked at the COVID tracker about race and ethnicity, and that is something that has been, luckily has gotten some attention in the media recently, and that we know there are huge disparities in regards to who's actually being affected by the COVID pandemic. I've talked a lot about socioeconomic status so far, and I think it's just important to note that socioeconomic status and race and ethnicity are inextricably linked in our society, which represents this very unfortunate and horrible oppressive society that we have created and sustained here in America, which means that people of color are often disproportionately represented among people with lower income or less education because of our American history. And so I think that's really important to hold as we think about health disparities and inequity, especially as we think about COVID. And then I want to just take a break here. We're going to talk more about immigration status in a minute. Do people have thoughts so far about how maybe these factors have affected their patients? And does anyone want to sort of make the link for us as we go from socioeconomic status and race and ethnicity and start talking about immigration status, maybe how those things are really linked, especially at this time in our political environment and healthcare?
I can provide some examples. This is Katie. I am a third-year student. I was formerly at CIC, and now I'm doing some results calls for COVID patients within the CHA system. And in terms of we're able to offer some resources to patients as they are kind of navigating this, in terms of food. And for a while we were able to offer an alternate care site. But there were some differences that I saw in terms of how eager people were, or how much they felt that those services were available to them. They some people would cite worries about, oh, if I accept this, will I go on a list somewhere, or will my name be tracked, kind of thinking about public charge type concerns.
Yeah, that's great, Katie. Thank you. Does anyone else have patient experiences of care so far?
Hi, this is Hema. Can you hear me?
Yeah.
Awesome. I'm one of Katie's classmates. I'm a third year also. I've been helping with calling patients who've been labeled as high risk by primary care docs at the Brigham. And I think reflecting on those experiences, some patients have been totally fine, when asked if they need help with food, medication, housing supplies. They have a good supply chain. Their family's really involved. But then it's been really, really sad to hear about other cases of families where they have an elder parent who's in their 90s, and that's the patient that I'll be calling about. And then the child of the patient works, has to work because they that's the nature of their job, and then has high contact with people, as you were discussing, just like is in contact with a lot of people because of the nature of their job. And they often like don't really have any workaround to avoid that risk of infection either for themselves or for their elder parent. And like it's been really sad to hear them say, like, you know, if something happens to my dad or my mom, like we can't really do anything about it and it'll be pretty devastating. So yeah.
Thanks for sharing. Does anyone else have experiences that they want to talk about? So let's go on to the next slide, Kathe. I want to talk about immigration status a moment. So at CHA, we work with a lot of immigrant patients who are really at high risk, especially during this time. So for our immigrant patients, a lot of them work skilled labor, hourly wage jobs, which affects a number of things. So it definitely affects their ability to work from home, already putting them at risk now of the ability to physically distance. And then also if they're laid off from work, that means that a lot of people are going without a paycheck, which puts them at very high risk for other things because of their already present socioeconomic status. And then I think it's also important to think about the neighborhoods that we live in. So a lot of our immigrant patients, at least at CHA, a lot of people are living in apartment buildings. There are a lot of people living in one apartment, a small apartment together, and might have like less sanitary conditions. So maybe that means that there are insects, rodents, mold, other things that are making the COVID situation more complicated, putting them at increased risk for transmission, and then also making complications worse should they test positive. And then also just thinking about how immigration status ultimately influences a lot of things. It influences people's socioeconomic status, housing conditions, their nutritional status, access to high quality healthcare. And then also a lot of our immigrant patients are facing a lot of racism or increased allostatic load from their life experiences so far. And this has been especially pertinent for what I've seen throughout COVID. And there's a great piece coming out in the Harvard Center for Primary Care blog tomorrow about immigration and COVID. So something good to check out. Kathe, you can go to the next slide. And so now Kathe is going to talk a bit about Respiratory Clinic, and then we'll talk about ICU after that.
Hi, everybody. So again, thanks for joining us. And for about the last, I guess it's about 6 or 7 weeks, I've been working at the CHA Respiratory Clinic. And so I've had direct contact with a lot of people, particularly our vulnerable populations that are served at CHA. But let me tell you a little bit about our clinic. So previous to the coronavirus pandemic, there was no CHA Respiratory Clinic. This operation was basically conceived and designed in about 48 hours. And by 72 hours, it was up and running. It is housed in one of the CHA primary care sites where the primary care practice was closed down. And the ground floor of the Broadway Clinic, which is near Winter Hill in Somerville, was opened up to this operation. So for those of you who don't know about Cambridge Health Alliance, which is where the CIC is based, we have a bit over 140,000 patients that are in Cambridge, Somerville, also Revere, Everett, Malden, and the rest of Metro North. And the majority of those patients are in at-risk categories. The respiratory clinic is staffed by family medicine and internal medicine providers pulled from all across Cambridge Health Alliance, but everyone is a primary care doc. The two people who designed it, the medical director is a physician assistant who's also medical director at one of our Malden sites, and it is actually Somerville, I guess, Assembly Square. And the medical director, Laura Hall, is a family doctor who previously managed the CDC AIDS outbreak in Haiti, and prior to that was working with Pivot, which is an international organization in Madagascar. So she's very well acquainted with outbreak management. So the respiratory clinic was designed to care for any patient who needed it. So we're seeing 3-day-olds for their first weight check who are born of COVID positive mothers. We're also seeing prenatal patients who are COVID positive or a patient under investigation, and everybody in between, on up to ill elders. The reason for cohorting our patients is because we could really concentrate infection control efforts in one site to try and not expose well patients to coronavirus, to be sure that our providers were really thoughtful about using personal protective equipment, and also to have a really robust infection control strategy on site. In addition, all of these patients, because most of our ambulatory sites are down to televisits, most of these patients would end up in the emergency department if they weren't coming to see us. So cohorting our patients, really thoughtful use of personal protective equipment, and decreased ER utilization. We've seen, I think the most we ever saw in a day in respiratory clinic was about 108. That was our busiest day. Right now, we've been hovering in the 60s to 70s most weekdays, sometimes up to 90s for the last week, and prior to that, it was about 90 patients a day. So some of the other emphasis in the respiratory clinic is that all of our docs, being primary care docs who are culturally aware, at least, we've had a lot of emphasis on patient counseling and education. And the respiratory clinic is just one part of a community-based follow-up system, which is really amazing, where as soon as a patient comes into our system, identified as a COVID patient under investigation or COVID positive, they are followed longitudinally until we determine that their COVID disease is resolved by a combination of respiratory clinic visits if they need it, and telephone touches on a fixed schedule. The phone calls they're doing, I think they're doing between 150 and 200 phone calls a day. And the other thing about the respiratory clinic is that we have worked hard to be agile and responsive to the needs of our community. So after all that, if anybody has a question, feel free to pipe up or interrupt me. I'll pause for just a second here. All right, perfectly fine. So what I'd like to do is tell you about just a few patients that I've seen, and you can see how all of the things that Rebekah mentioned are play out in reality. Oh, before that, sorry, I forgot about this one. I don't know if you all are aware of this Mass Department of Public Health COVID-19 dashboard. It's a very interesting place to keep track of what's happening. It's updated every day, so this is yesterday's update. And it does look at newly reported cases and deaths and so on and so forth. There are some graphics. So here's a very encouraging graphic about daily and cumulative confirmed cases. The percentage of positive tests per overall test, also encouraging, that we were up as high as 33% positives, and now we're down to about 10% positives in total. You can see where it's growing, you can see which counties. Anyway, I won't go through all of this, but I think this is a nice place to see information. And there are also reports, not only by age group, but also when known, sorry, I don't want to make anybody dizzy here, but case hospitalizations and deaths by race and ethnicity. So you can take a look of those who have a reported race or ethnicity, what the percentage is looking like. And it is quite different than what the overall percentage of each race / ethnicity are in our general population. Alrighty. So first case was someone I saw about my first week in respiratory clinic. She's a 38-year-old Haitian woman who wasn't coming in for herself, but rather in for her 5-month-old son for an appointment. So in the respiratory clinic, we are generally not testing children. Up until the recent reports of the Kawasaki-like syndrome, which is following a very, very small percentage of children with COVID-19, we were feeling like kids, and they do, kids generally come through this very well, and our recommendations wouldn't change whether they were positive or negative in general. So he was a very cute little guy who was completely undisturbed by all of my personal protective equipment. He had had a fever up to as high as 102, runny nose, and a dry cough for the last 3 days. So it looked like he had a cold, basically. As I got more of the history, though, his mom works as a certified nursing assistant. She takes public transportation to 3 homes daily where she sees people with disabilities who are unable to leave their houses. Her husband was driving for Uber, but is no longer driving because he's worried about catching something. So he's been staying home with their son. And she feels like she would prefer not to be going out and run the risk of getting sick. But number one, she's the sole wage earner. And number two, she is really attached and devoted to her patients. And the baby does not go to any place else for child care. So what do you all think about this situation, and what would be our role as a healthcare system for taking care of this woman and her son and anybody else you think we should be responsible for? Don't be shy, friends.
I think one of the things that could be one of the first steps, I guess, would be kind of using some type of, asking a series of questions about, public transportation and all of these things that kind of make it difficult for her to potentially care for her son, but also kind of asking about her home situation, and while also being respectful of, like, cultural considerations. But that could just be one first step.
Yes, for sure. Learning more about her situation, and she doesn't have any other option for transportation other than public transportation. She wears a mask all the time, and she never takes her mask off when she's with her patients. But she is worried about potentially getting whatever her son has to her patients. So how do you all think, perhaps it's a little obvious, but perhaps not entirely, let's think about social determinants of health. And this woman, we have seen a disproportionate number of, in our population, particularly people who were born in Haiti, who now are working as personal care assistants or certified nursing assistants, who ended up getting sick, who are similar to this woman. Any other thoughts?
I'm thinking about, there was that New York Times article, maybe like at the very beginning of the pandemic.
I do wonder if, about concern for losing her job, should she develop symptoms, and sort of trying to weigh the risk to the people she's caring for, obviously who she cares about, but also, concern about her family's income as this kind of sole income earner at that point.
Right, Erin, exactly. She's in a really tough spot, because if she gets sick but prioritizes keeping food on the table and the lights on in her home, and just tries to not let anybody know that she's not feeling well, she puts her patients at risk, and on the other side of it, she's putting her family at risk. And Hema, what were you talking about with the New York Times article?
Yeah, I think at the very beginning of the pandemic, there was this like graphic on the New York Times about, it was like comparing the types of jobs that people have, and like either how exposed they are on the y-axis, and then like to potential COVID, and then on the x-axis there was like how much they interface with other people. And like in the very top right corner of people who were like had the greatest risk of being exposed and the greatest interfacing with other people were like PCAs and home health aides. And it's just like really interesting because like as her doctor, like are you just taking care of her? Are you also thinking about her patients, even though you're not necessarily their provider? And like how I guess paternalistic maybe can you be in giving recommendations for what she do? Oh yeah, Katie, thank you.
Yeah, well, and to make it even more interesting, if you will, she was asymptomatic. She felt fine, but her son was unwell. So other thoughts, and one of the things that I'm going to encourage you to think about, and we'll talk about after we're done with our cases, is what sorts of ways can we as medical professionals remain engaged in advocacy for our patients and for these health inequities, which are showing up even more starkly in these days of COVID. But anyone with other thoughts about this woman?
I'm thinking also about the financial assistance that she may or may not be able to expect from the federal government and her state government, depending on her immigration status, her husband's immigration status. Either she is not expecting a stimulus check at all, or should be rightfully expecting a stimulus check and may be excluded from one if somebody she's filing with jointly is paying via an ITIN number. So just thinking about the safety nets that are set up, that are supposed to be set up for everyone living in the US during this time, may or may not be set up to tide them over if she's not able to work for a while.
Yes, and taking it out on a slightly different angle, if we say, well, you're potentially exposed to COVID, potentially, you have no symptoms, your son is sick, he hasn't been tested, and we can talk about if we should test him or not. So if we pull her from the workforce, who's going to take care of those 3 vulnerable people at home for whom she provides full care? It gets pretty complicated. And as I think, as you said, where is our responsibility as healthcare providers in a very specialized clinic? So one of the goals of our clinic is to minimize contact with our patients because we're trying to keep our workforce intact so that we can continue to provide for them. Interestingly, of all of the medical assistants, nurses, physician assistants, and physicians at the clinic so far, no one has gone out with COVID symptoms. So we're about 6 weeks in. Of course, now probably 6 people are going to call in tomorrow sick. But so far, with judicious use of PPE and bringing patients in one at a time, putting them directly into a room that is fully cleaned between every patient, and the providers spending as little time as we can to perform the functions that we need to perform in the room is working pretty well. But should we be spending more time with them to do more, for example, social problem solving? It's a lot. Any other comments about this particular case or questions? We'll have time for discussion later. I'm going to go ahead to the next one. So MB is a 40-year-old gentleman who works in construction. He has a past history of hypertension and is a recovering alcoholic. And he came in with a 5-day history of fevers and myalgias, as well as a dry cough, and a little bit of trouble catching his breath since yesterday. So getting, for example, if he's sitting and he goes to walk to the bathroom, he feels a little short of breath, and it's hard to climb the steps into his house. So we talk about how this is most likely COVID-19 because the symptoms are quite typical. And I go ahead and do a nasopharyngeal swab, and then we start to talk about how important it is for him to protect the people around him. And we start talking about his living situation. So he lives in a 2-bedroom rental apartment with 5 other adults. He's actually sleeping in the garage, and his brother also sleeps there. However, his brother's an alcoholic, and he goes out every night to buy alcohol in Chelsea and hang out with his friends. They must be hanging out outside because there aren't any bars open, but he can't get his brother to stay in. He tried hanging a sheet sort of along the ceiling of the room to protect himself a little bit, but he can't really keep from his brother. He also said that his significant other and their children live nearby, and he was recently over there and spent the night, and he's really worried about having infected that family. However, since the mother of his children is on subsidized housing and he's not on her documentation as a domestic partner, he can't stay there. And he's also continued to work construction because he needs the income to take care of himself and take care of his kids. So what do you think about this situation?
It's so hard. Because I feel like the easy, like simple answer is he shouldn't be working and he shouldn't be living with these people because there's a risk of spreading. But sorry, I wasn't sure because I was frozen.
No, you're perfect. Thank you.
There's so many things that are barriers to the like easy public health answer of he needs to limit his exposure. So it's like hard to think what should be done.
Yeah, well, we didn't choose the easy cases, guys. Come on. What should we do for him, or how can we counsel and support him?
I was wondering if there will be like quarantine centers for him available, just have a space to live alone, but it's kind of what kind of resources are there for that?
Yes, so that's a wonderful question. And he came in very early in the pandemic, before the alternative care sites were as available as they are now. So fortunately, there are some sites that are available. Some of them are for patients under investigation. Some of them are for only known COVID positive patients, where they can be cohorted with other positive patients, but have their own room and food. And some of them actually also have on-site medical attention. So that's a great temporary fix if it's available to him. Unfortunately, when I saw him, that was not an available resource yet. And of course, that still doesn't quite solve the problem of the other 4 guys living in his house with his brother who's going out. Oh, and he also told me, by the way, that his brother who goes out every night is having the same symptoms that he's having. So we talk about social pressures and stressors and how important it is to stay in. However, if, as you said, Chris, if you have to make a living to support yourself and your family and you don't have the money to have a safe space and other people in that space are unable to self-isolate in this particular case because of addiction, it helps make more clear why the social determinants of health are becoming more starkly delineated. What other thoughts do folks have about this gentleman?
Kathe, I was wondering if there are kind of cross-sector resources available for folks who need to work and whose work has not gone away due to COVID and need to work to support their families. In terms of kind of filling gaps, are there resources where you can connect people to legal aid that will help them apply for some of the payday protection loans or some of the money that kind of is the goal of the money? I know that at some certain pots of that money have run out, but some of the money that can support folks that either have been affected by COVID directly or whose jobs have been affected.
Oh, thanks, Erin. There, the resources, at least within Cambridge Health Alliance, are run pretty thin. We do still, however, have our patient resource coordinators, which are the medical social workers who are doing all televisits, of course. that are able to help patients. There's also a very robust services guide, which is mostly used by the folks who are doing televisits. So one of the things that we've been able to do at Respiratory Clinic is if we have someone, for example, like this who needs alternative housing, and this is part of the rapid evolution of our system. This just came up, I think, 10 days ago, probably, is we can call one of the people upstairs or at home who's doing all telephone visits, who are better connected to all of these resources to see if they can find solutions for patients. So things like getting them into housing, like domestic violence shelters. We have seen a very large increase in domestic violence. Like food delivery. I saw a patient 3 days ago who is out of work and has COVID, continues to have symptoms. So, and his work is not, he works at a restaurant, which is closed anyhow. And there's some volunteer organizations who are doing food delivery to people for up to 2 weeks who have COVID. So being able to centralize those resources and connect people to them, that's a specialty of the community outreach group. Unfortunately, I don't think these resources are being shared across hospital systems. So unfortunately, we haven't been able to organize to that degree, at least not yet. Any other questions about this guy? Well, let me go on to the next one. Oh, by the way, going back to our previous 2 patients, I did swab that 5-month-old baby. He didn't think much of it, but his swab was ultimately negative, although he might still have it given there's a 30% false negative rate. And the gentleman we just spoke about was swabbed, was positive, and he ended up recovering just fine. He didn't get too much more sick. So another question that we've been asking ourselves is, what is best care? Because that really isn't universally defined by we humans. So Ella's an 80-year-old woman from Guatemala who had recently relocated to the United States. She came into Respiratory Clinic reporting fever and body aches for about 4 days, also some diarrhea, and she couldn't smell anything. 2 days prior to coming to us, she developed a dry cough and was having more trouble breathing. So on arrival to the clinic, she wasn't able to walk, so we had to go fetch her from her car in a wheelchair. And her room air O2 saturation was 82%, and she looked unwell. So as we were rolling her into the clinic, our front-facing people, so we have some medical assistants who meet each patient as they come in. They check their temperature, their heart rate, and their oxygen saturation. And when they saw her sat so low, they called emergency medical services for transport and got her into an exam room and placed an oxygen by nasal cannula while one of our providers was suiting up, putting on their PPE, personal protective equipment, to attend to her. She had a rapid improvement of her oxygen saturation to the mid-90s with 4 liters of oxygen by nasal cannula, and started talking with the provider in the room. Now she's 80, she speaks only Spanish. The provider in the room did speak Spanish, so that was helpful. The provider, the clinician, family doctor, spoke Spanish. But there was really not a lot of time for much conversation between when she got in the room and when the ambulance came. This was during the very early days of our clinic when we had not yet experienced the surge here in Massachusetts. We weren't sure if at some point we were going to be taking care of these patients for a few hours until the ambulance arrived. So the ambulance came after a very brief history and physical. We called her family member who was outside in the car and let them know she was going to be taken to the hospital. And as she was loaded into the ambulance at the outside of our building, the staff accompanied her. So Spanish came back in, the staff member, tearful, saying as she was getting put in the ambulance, she was crying out for her granddaughter who was too far away to reach her, saying, "I don't want to die alone in the hospital." So this was and we had more than one case of this nature. So what do you think, guys?
Hi, Kathy. It's Chai.
Hi, Chai.
It's a really sad situation. I think in these cases, especially now that there are a lot more strict restrictions on who can see patients, the brunt of the caring is falling on healthcare workers that are there and present who can, I guess, offer some companionship to patients during these really difficult and scary times.
It's absolutely true. There are so many restrictions on visitors. So is the right thing to do to send this woman to the hospital by herself? What do you think?
Well, what is the alternative, right? This is Aaron Hoffman. Like, this is one of those rare times, I think, and there's been a lot of them in this scenario where
it seems like is anyone else talking? I don't think so. It seems like it might be helpful to take a moment to talk with her, and as long as she's stable. It looks like she was stable once she was given some O2. So I think rather than just like immediately racing her to the hospital when she's clearly in distress and doesn't want to go, it seems like it would make sense to like just take a moment, have a conversation, and really talk through the options a little bit more, at least until you get to a place where she's a little bit more comfortable with the options. I don't think there's any need for her to go right away, it seems like, as long as she's stable enough.
Yeah, so maybe we could have spent more time with her, and I'll tell you what this and other cases like it led to in our clinic. But Aaron, you were talking about options. I know I think you've also been working in a COVID type clinic, right?
I have been. I've been staffing the Mass General Clinic in Chelsea, and
oh wow,
seeing an extraordinarily high volume, upwards of 300-400 patients a day. Not me personally, but in the clinic. And so, yeah, there's a lot of folks coming in, lots of people getting transferred out in ambulances to the hospital. And it's heartbreaking to see things like I've witnessed very similar scenes play out. I think that this does, because of the severity of the situation and the resources that are involved and that we're putting into this, like, we kind of have to be a little bit almost patronizing to people and what alternative do we have? If someone's O2 status is 82%, they need to go to the hospital. And especially if there's a reasonable likelihood of her surviving this. I mean, an 80-year-old woman, she could die from COVID in the hospital, but there's a reasonable chance that she will get through it. It's not like it's a death sentence. And so, yes, she should have a moment to say goodbye to her family, but I do think that we don't have the time necessarily when someone's saturation is that low to like have an in-depth discussion around all the things that are going on and why we're making these decisions, unfortunately.
Sorry, what other thoughts do folks have? This brought about a lot of discussion in our clinic, for sure.
This is Joy. Speaking from the inpatient side, which is where my experiences have been, if she's someone who comes inpatient, and I mean, presuming she's not going to be intubated pretty urgently, we have the ability to take time on the inpatient side also to connect them with their families. I think less so at the beginning of this, but as we got further on, there were tablets that people were trying to institute on the floors so that communication could be made. So just because they're going to the hospital doesn't kind of like cut off the ability to communicate with the patient. I suppose with respiratory staff, but a warm handoff would be appreciated, I suppose.
Yeah, so thinking about ways to help her stay connected, thinking about possibly delaying a transport if she is at least somewhat stable on oxygen. What else do you think and would be worth considering? So it's one of our more at-risk patients, being that she's 80. I think she was diabetic. I don't remember her comorbidities. I was actually clinic lead that day, so I was more of the clinic director. I didn't see her, but I heard about her. Any other thoughts?
Just to add on to the previous comment about, having accompaniment, like medical staff, I would imagine would be very busy. And actually, I've heard of a facility has transferred a handful of CNAs into a team who focuses on helping patients telecommunicating with their loved ones by running FaceTime. And I also think that the psychological toll heavily affects the quality of life. The sense of loneliness, isolation, being in the hospital. I think that, just the psychological aspect has to be cared for as well.
I think
Thank you.
This is
go ahead.
I think going off of that, I think that might have been Jasmine speaking. I think another option for this woman is to not go to the hospital at all, and that she could choose to return home if it's possible for the respiratory clinic to set up home oxygen for her. Because I think that someone of this age, especially if she has other comorbidities, she is at high risk from dying in the hospital alone, which is definitely her fear. And I think that people should have the autonomy to say they don't want to go to the hospital, and to choose to go back home with a low O2 sat, and then seeing if we might be able to help these patients get home O2 or other supportive, comfortable measures.
Yeah, so it was an interesting time in our clinic. So I'll just share with you briefly. So she, first of all, the good news, she ended up going to the hospital. She didn't like her nasal O2 and she kept trying to take it off, but she did fine. She was there for about 3 days and got to go home. Fortunately, so she did very well, though there was no way to know that at the onset. I just want to mention that as far as helping patients stay connected with tablets and phones, Erin, I don't know what it's like with you, with the population that you've been seeing, but our CHA population, a lot of these folks do not have stable phone service. So FaceTime is only available if you have an Apple iPhone, I think, and so they don't have that. They might have other video chat, but they only have cell service with Wi-Fi. Otherwise, they haven't been able to pay their bills. So that connection is a little tenuous, even if it's video. So what we ended up doing in patients with this, after much conversation about can we send someone home, how fast can we get them home hospice? Unfortunately, we've never been able to get home oxygen from Respiratory Clinic. We decided that the right thing to do is not to activate EMS as soon as a person comes in, unless they look like they're in significant respiratory distress. I mean, if they really look like they could die in the lobby, then yes, we're calling the ambulance. And we have a few people like that. But the other folks, we're letting them get in the room and get some oxygen on them and taking some time. We've decided to prioritize that over throughput, and our providers, our clinicians, I don't say doctors because we're about equal numbers of PAs and MDs. Our clinicians decided that was where we wanted to prioritize our time, and we were willing to undertake the risk of continued exposure to these folks. So we're taking time to sit with them. We're also we decided to go a little bit rogue, and we are allowing, especially non-English speaking elders or patients who look particularly ill, to bring whoever drove them to the clinic, whoever came with them to the clinic, to come into the office room with them. for some shared decision making and shared understanding. And we're taking time to ask them what is most important and what they're most afraid of and what the right choices are. And sometimes the patient's very clear they want to go to the hospital, and sometimes they really don't. They want to try and hold off another day, which we're doing in people with O2 sats of 91, 92, 93%. Maybe they go home and come back the next day and see how they feel. In folks this low, had she wanted to not go to the hospital, we could have tried to get an urgent hospice referral and get someone to her house that day to help with symptom control. We're filling out most forms, so the limitation of treatment forms. Sometimes in the exam rooms, we're ensuring that we have the healthcare proxy. So a big shift in our care, realizing that not all patients have as their number one priority to survive. Some patients, their number one priority is to be with their families. So other thoughts or comments on this thing? We have one more case, then we have a little time for discussion. All right, well, let me go on to our next case, which is from the ICU. So handing off to you, Rebekah.
Hi. So I've been working a lot in the ICU throughout the pandemic so far. And this is a case I recently had. He's a 49-year-old Vietnamese-speaking man. He came to the hospital. He's homeless. He has no healthcare proxy. He was initially diagnosed with COVID. He had his first positive test at Salem Hospital on April 21st. And from there, he got moved into, he just left the ED. He got moved into one of the hotels that has been set aside for any homeless folks who are positive for COVID. So he was there. And then he came to our Everett Hospital ED on April 25th, so just a few days later, because he was having worsening dyspnea. And then he was on the floor for a while in our hospital. And then on May 1st, he moved over to the ICU for increasing oxygen demands, and he was intubated after having prolonged desaturations. And over the course of his ICU stay, he developed, his respiratory status actually slightly improved, but he developed acute tubular necrosis, which is what we're seeing in a lot of our ICU COVID patients, unfortunately, requiring dialysis. And so he had a dialysis catheter placed, he got dialysis, and then shortly after that, he actually developed some sort of coagulopathy for which there are blood tests still pending. And then ultimately had a massive intracranial hemorrhage and died. And so I think for me, this case was quite hard. Our health system and our society has fairly clearly failed him in a lot of different ways. I think he's significantly at risk in a lot of ways. So I wanted to just bring this up and talk about what are your thoughts about how our systems actually failed this patient, especially such a young patient to die at such a young age. And what are some things that we could do about it from a systems perspective to help move more towards health equity for a patient like this? What are some of the things that what are some of the ways, let's start with, what are some of the ways that our system did fail this patient? What are, what could have or should have been better from his SDOH perspective?
I guess to get us started, we may have failed him just and the fact that he is homeless and the outreach and precautionary measures being taken to prevent the spread of the virus was probably implemented in the homeless population much later and a lot more difficult to enforce. So just the fact that he was struggling with housing issues and being unable to control his environment for a good portion of his time is one way that society as a whole, I suppose, failed him.
Thanks, Chai. And what are some ways that you think we could better address this as a society? Like, obviously it would be great if he could have a home, but what as physicians can we do to help implement that, or maybe advocate for that? Or do you think we have a duty to intervene in this way?
And guys, if you're typing things, I'm really sorry, I don't know how to find them. So please speak up with your microphone.
Brandon, do you want to expand more on your comment? What would that, what sort of initiatives would it take to get housing as healthcare?
Yeah, I think the intricacies of this path are daunting, but I feel like we shouldn't say it isn't our role as healthcare providers to perform that kind of advocacy and restore power to these communities. I mean, I think some of the proximal steps are to use the kind of like personal and professional privilege that we have to raise awareness of the needs of this population. And some of the ways we do that are through telling stories. Other ways we do that are like taking doctors' incomes and like transferring wealth to either service organizations or individuals who like just can't afford a place to live. And some of it is like using the kind of like stance that we have. Like we have professional networks, we have inroads to policy and academics, and tilting kind of the goals of the work of our peers towards the service of this population, I think could go a very long way. There have been some really inspiring examples of, in-hospital initiatives to do this. So the MGH is working on putting together a consult team to be called when patients who experience homelessness are set to be discharged to a place other than a home, to try to make sure that to the best of the hospital's ability, their care plan is made in a way that is responsive to their housing status, and that they're well connected to the available, even if limited, resources that like state and federal grants provide. So I think there's like opportunities for linkages there. There's a program at BU called Street Cred that hasn't specifically focused on the homeless population, but that has kind of demonstrated how the kind of non-traditionally clinical aspects of healthcare, like if we think social determinants of health include wealth, could be integrated in a clinical setting. So get your tax return done while you're in the hospital or at your primary care appointment seem like kind of good things that we should at least be open to, if not be on the front lines in innovating as healthcare providers.
Yeah, that's terrific. Thank you. And great examples. The University of Illinois at Chicago also has a very similar example of investing in housing. So they actually worked with a lot of different housing organizations in Chicago, and then placed all of their ED high utilizers into homes. So the hospital actually paid for the apartments for the ED high utilizers, and they tracked outcomes of their high utilizers, and a large majority of them were then able to stay home without having to visit the ED more frequently. And in the article, there's actually a piece where one of the patients went in the ED just to tell all the nurses hi because he hadn't had to go back for a while. And I think, in regards to this case too, thinking about the food insecurity for this patient, he didn't have any primary care doctor. He had a few underlying conditions that were undiagnosed before coming into the hospital. So some mild diabetes and hepatic steatosis. And then also, just the allostatic load of living on the street, not having any family members is quite a toll. So when this man died, we actually were essentially multiple doctors in the hospital were his acting healthcare proxies. And we had no family to call when he passed, so it was quite a sad situation. And it leaves me thinking about how maybe things could have been different for him if we had better systems in place to support people like this.
I'll just pipe up to say that there is a still somewhat grassroots movement pushing the city of Boston and the hospitals in the greater Boston area to work on essentially a pooled source of permanent supportive housing units, much like UIC. So if folks want to be involved with that, I'm happy to connect you to that group. I think it's promising, and it's hard to know if the argument should be made on kind of the moral basis or on the economic basis or both. But it seems like BU has been probably the strongest player in this in Boston so far, taking that step forward and saying, yeah, we're going to try giving housing to the patients that are coming back to us because they're sick, because they don't have a place to be, and especially under like capitated payment models. I think healthcare institutions have increasing financial incentives to do what seems to also align with care of the patients.
Thank you.
So Brendan, thank you so much. And I just figured out how to see the chat, so sorry guys. Then that's a wonderful segue to think about what we can do as healthcare providers, as clinicians, as humans, to support the patients who most need it, and to try and work with our governmental leadership to address some of these inequities. I'm heartened that patients have places to go to get care, and terribly disheartened at the proportion of vulnerable people who are needing it. So I don't remember, do we have, oh, there we go, discussion. So I would love to hear from folks. I know at Cambridge Health Alliance, there is a whole group that's been working on pressuring, and perhaps encouraging is a kind of word, but it's really pressuring our governmental leaders to do things like provide housing, like provide rent relief, and eliminate oh dear, having people removed from their lodging for failure of payment of rent, and thinking about releasing people from incarceration to ease the burden there on providing personal space. What else have you all heard about? Or Rebekah, what have you all been working on through the residency or talking about?
So in regards to the residency, I know Joy might have some things to say. I know that we are developing a COVID-19 working group within CHA. Right now, I'm actually really encouraging some of our more academic or policy-related folks to be really studying the social determinants of health and people's complications and outcomes from COVID. And then more at a policy level, I know there are a lot of active groups in regards to health equity, immigration, housing within the greater Boston area, and then also nationally. And then also there's a pretty big movement now in regards to gender-based violence amidst the COVID pandemic. So those are some of the things that I'm involved with. I know there are a lot of initiatives out there, but, and then also, sorry, so the one other thing that I guess I've been involved with throughout this time is looking at substance use and opioid use disorders. And I've been looking at that more primarily in like rural America, rural Appalachia, where I'm from. And so that's something else about how, thinking about how COVID itself has its own complications and mortality rates, and then it's also affecting people in a number of different ways that is causing morbidity and mortality, not from the virus itself, but from the implications, the like structural implications from the virus. Joy, did you want to add anything about residency work?
I think that, I mean, I think we'll see a lot more from the residency, but I think that a lot of the residents have been preoccupied with the fact that family medicine residents have all been redeployed inpatient. I know that there's been internal advocacy and concern about knowing that Everett has been servicing a lot of the vulnerable patients coming from the Chelsea area, and feeling that the resources that we normally have at our hospital may not be adequate for the surge that we're seeing. So there's a lot of, there's been a lot of advocacy from people about making sure that we have the right resources for those patients in our environment. And I'm sure with that moving forward, as residents come back to the outpatient environment, there'll be more work on that front as well.
In terms of the data that Rebekah brought up at the end, this is Catherine, by the way. I know there's a bill in at the Massachusetts legislature right now. I think it actually has been active as of yesterday to mandate reporting of COVID-19 confirmed cases and mortalities by race, ethnicity, more granular about where people live. Just yesterday, I think there's an analysis released by Nancy Krieger and a couple other folks at the School of Public Health with data that the Boston Globe got a hold of and passed to them through mid-April, that was able to show, I think, even more clearly than it had been before, how disproportionately affected neighborhoods with higher concentrations of folks of color are, and along other sort of axes of inequality. But it was really hard for them to get access to that data. So I think it's been through the House and maybe the Senate now, and hasn't been quite signed into law yet, but hopefully getting there closer, just to know what we're dealing with and to be able to study it and to be able to intervene on it more effectively. And hopefully with the contact tracing initiative that's going on will be helpful for identifying hotspots and not just documenting what's going on, but helping make it better.
Thank you so much, Catherine. And there are many initiatives happening as far as trying to improve the lot of our patients. There is so much more to be done, though. Rebekah, from your public health standpoint, what do you see as perhaps I'm going to put you on the spot a little bit. What do you see as the biggest lessons learned or work to be done in the coming months, years, couple of years after this? What do you think?
So I think that the COVID pandemic has really highlighted the weaknesses within our healthcare system. And in regards to the public, population level health, what I personally would like to see done, this is a very long-term range, but the health of our population would be much better off if the federal funding for healthcare, housing, education were more combined and then utilized in a more equitable way. So that way we could actually reallocate some of the healthcare dollars to housing, and really put an emphasis on these social determinants. And so in the beginning of the COVID pandemic, I think a lot of people were saying the virus does not discriminate, but we've seen now how there are people who are much more at risk and suffer much more severe complications. And so I hope that if anything good comes out of this, that it will be a wake-up call for our legislators and the federal government about how we could maybe better allocate our funding and maybe give a little bit of push to reconsider at least what we consider health and how we spend those dollars. So we know that health largely does not happen from a medical care visit, but rather it happens in our neighborhoods and the places we live and the food we eat and the relationships we have and so on. And so I hope that that's what happens out of this. And I think there's a lot of really good grassroots work about that right now. And I hope it continues. And I hope that our legislators and our like HHS, HUD, and the Department of Education may also see the benefits of collaborating more.
Thanks, Rebekah. How about from the rest of our participants? What are you seeing as the places? And maybe we'll end with this. It's about 20 after 6 now, and thanks everyone for joining us for this event. But what are, of all of you who are still coming up through our educational system, and some of us who are already through it, what do you see as the next actions that we might take? I can certainly say from Cambridge Health Alliance, there are frequent reminders to engage in activism through reaching out to our congresspeople, pushing for bills, signing petitions, and that actually does make a difference. And so taking the few minutes to act on these initiatives that have been, even something that's been started by someone else, is meaningful. But what else do you think?
I just want to, this is Rebekah, and I'll make this brief, but I think it's important to note that especially in an election year, a lot of people on this phone call or within Harvard are coming from other states. And so really trying to activate voters and thinking about how, what are the important issues for the upcoming election and how can we influence that? And I think that's something that's going to be hard in the midst of a pandemic. And so I hope that we can all continue to consider that and try to activate ourselves and activate others in regards to all of the other issues, as well as COVID and health equity issues at stake, and talking with our legislators, talking with our friends, our peers, our colleagues about that.
Thanks, Rebekah. Any other comments from our participants or ideas, requests? If any of you are interested in other events like this or something similar having to do with perhaps folks who are actively caring for COVID patients in the outpatient setting, in particular, more having to do with primary care, you can certainly reach out to me. My email address is on the Center for Primary Care website, or to Megan or to Erin, any of us really. But any final comments from you all?
Kathe, I just want to, this is Erin Farron. I just want to thank you and Rebekah both for leading this session, and to so many people for participating and for everyone's engaged and thoughtful discussion. I just wanted to, as we talked through the cases, one of the things that kept coming up to me was really how much of a toll this is going to take on our providers, not only in the acute caring for COVID patients, but in kind of acknowledging some of the disparities that are becoming very clear. And I think perhaps like a future opportunity for discussion is really how to take care of the people that are taking care of our communities, and how to support them as providers, as educators, and as community members, because I think that we need to find a bright side to this situation. And I think if we can be better community members to each other, I think that there's a long way to go, but we can try to find a bright side to the situation. So thank you all for the work that you're doing and for participating in this discussion. And I just want to raise that issue because I think it keeps coming to my mind as you talk about the cases, how hard this must be for you as frontline caregivers.
Well, thank you, Erin. And I think that for lots of reasons, it's tough to be in the medical profession. And it's also, one of my friends who's been out of clinical medicine for about 10 years came back into clinical medicine because of feeling like this is exactly the right time to be in medicine. And it's also exactly the hardest time to be in medicine, at least since I started as a physician about 30 years ago. So the potential for growth and hopefully for change and for activation is great. Yes, it's really hard, and we have to do our best to protect our patients and care for those who are vulnerable and care for all of their friends and their families who are vulnerable. And for me and for many of us, maintaining hope that this will catalyze some change to improve a lot of people's situations and make them a little less fragile, I guess. I mean, these are strong, resilient people who've been pushed over the edge of their strength and resilience. So, and for anyone on the call, please do take care of yourselves. I know a lot of systems have care available to providers, medical students, and so on, help process this information and to help guide you in getting the care that you need. So feel free to reach out to us, of course, but also to your systems for the students, to your mentors and supervisors. So I think with that, at 6:30 on the dot, I'm going to say thank you so much, everyone, for joining us. If you have other questions, comments, or want to share about this offline, so to speak, please don't hesitate to reach out. You can reach out through